In the previous lecture, we focused on the rise of bioethics in the context of Nazi medical experiments, and then also the sort of basic underlying idea of the way medical experiments work and should work, and the way that the researchers should interact with their research subjects. In this lecture, what I want to do is focus in on applying some of these ideas to a particular case. In this case in particular, I want to look at the death of subject 13. So as the article tells us, Dan Markinson was diagnosed with schizophrenia and various other mental illnesses, and was enrolled in a clinical study to study the effectiveness of particular antipsychotics in 2003. The physician that got him enrolled in the study was also a researcher in the study. Additionally, this same guy deemed Markinson incapable of making decisions regarding his own care, but then a week later deemed him capable of making decisions for himself and had him go ahead and sign up for the study. And additionally, as we find out in the article, that despite the outcry from Markinson's mother that her son wasn't getting better and in fact was getting worse and that she was really worried about him, the study went on and then Markinson finally committed suicide. And so the question we want to ask in the context of this particular trial and this particular situation is, did Dr. Olson fail in his obligations to Markinson or as a researcher or as a physician? In order to do that, we first want to look at what the role of the physician is. So remember, Dr. Olson was both a researcher and a physician, and as such, he played multiple roles as regards Markinson. So it's certainly controversial and debatable over what exactly the role of the physician should be, but most people tend to agree with an idea similar to this, something like this. The role of the physician is first and foremost to her patient. As Leon Kass puts it, the physician must produce unswervingly the virtues of loyalty and friendship to his patient. So exactly what that entails on behalf of the physician is certainly questionable, whether or not that means always listening when the patient says, do X, don't do X, or whether or not it means the physician should just go ahead and do a procedure that she thinks is best for the patient, no matter what the patient says. Those sorts of things are debatable, but in either case, the physician is worried first and foremost about the patient, not about the hospital, not about the physician herself, and not about research that might be benefited by treating the patient in one way rather than another. Under this understanding of the role of the physician, as Markinson's physician, Dr. Olson had an obligation to do what is best for Markinson, regardless of the wider benefits of the study. And so in this case, what it looks like, at least initially, is that Dr. Olson may have failed in his role as a physician in particular, although not necessarily as a researcher yet. However, there's one way that we might be able to respond to this, and that's the fact that Markinson did give his consent. And by giving his consent, perhaps he went ahead and said, look, I'm going to regard you, Dr. Olson, as a researcher now rather than as my physician, and you can regard me now as a subject rather than as a patient. We're going to have questions about Markinson's consent, however. Remember, it's not good enough for him to just assign a piece of paper. It needs to be valid, informed consent. And so a few concerns we might have just off the bat about it is that he was deemed incapable of making decisions one week, and then the following week was deemed capable and signed up for the study. Additionally, it looks like there might be worries about coercion. So for instance, it looks like maybe Dr. Olson coerced Markinson into signing up for the study by telling him his only two options were either participate in the study or be reinstitutionalized. And then finally, along with that, was the idea of, was the consent truly voluntary? And so, if it's coercive, it's not truly voluntary. If they were forced to do it, then they weren't really volunteering to do it, even if, of course, he signed a piece of paper and said yes. The final thing with that is that we might worry that he didn't have all the information to make it voluntary either. And so Markinson's mother specifically mentions that even though Dr. Olson says that Markinson signed a piece of paper saying he could withdraw from the study at any time, that Markinson's mother thinks that Markinson may have not really known that he could have done that. But since he gave his consent, does this waive the doctor-patient relationship? And so Hellman and Hellman deal with this sort of response to their concern about research violating the doctor-patient relationship. So the general way that this argument would go is to say that even if clinical research violates the doctor-patient relationship, Informed consent of the research volunteer waives the right to that relationship. But Hellman and Hellman argue that such a right is inalienable. That means it cannot be waived under any circumstances. But how do they argue for that, and why do they argue for this? Well, according to them, the right of a person to a proper physician-patient relationship derives from the dignity of all persons. Just as persons have a right to make their own decisions, that's what the general principle of bioethics on respect for persons says, they also have a right to be treated a particular way by their physicians and regarded in a particular way by their physicians. And so Hellman and Hellman, in effect, are arguing that the right to the relationship between a physician and a patient follows from the physician's commitment to respect for persons. So for the same reason that the doctor is required to get informed consent from a patient before doing a procedure, he or she is not allowed to let a patient give away her right to be treated still as a patient by her physician. So you can take whatever stand you want on this argument. Certainly, Hellman and Hellman think it's a bad argument. But on the other side, you might think that, of course, if someone gives informed consent to be a participant in research, they should know what goes along with that. And since they know what goes along with that, at least if the consent was truly informed and voluntary, then there's no reason to have to treat them differently than what the research program says to treat them, or how the research program says to treat them. But even if it's the case that consent would waive the patient-physician relationship, the question we have in the case of Markinson is, was the consent valid? So, as I said before, valid informed consent is more than a signature. It requires information, that's the informed part. It requires a capacity for decision-making, that's the consent part. And it requires freedom of choice, that's the whole thing. It's not, again, good enough to say, oh, well, you have to choose one or the other child. I'm going to kill one or the other, you have to pick which one I kill, and they're both your children. We normally don't consider that a truly free choice. And so we want to make sure we don't have similar sorts of choices in the case of informed consent to participate in research. So this is what makes questions about whether or not we should do research on prisoners kind of interesting, because oftentimes research on prisoners involves letting the prisoners get out of prison early or have some sort of other perk while they're in prison in exchange for them participating in the research. And so we might worry that those aren't really free choices. They can either be a research guinea pig or they can spend more time in prison, neither of which are really good choices, so neither of which are particularly voluntary. But so in that context, though, we want to ask the question is, if Markinson was incapable of making decisions just a week prior, could he really be capable of making a decision now? Additionally, we want to know, did he really have all of the information? Specifically, about what options were available to him. So again, Markinson's mother seems to point out that he didn't really know what options were available to him, even though Dr. Olson said that he signed a piece of paper that had all the information on it. Finally, was he coerced into research and into continuing the research for fear of psychiatric commitment? So again, Markinson's mother argues that Dr. Olson basically coerced her son into staying in the research by saying that he would either have to participate in research or be institutionalized. So all these are reasons to doubt that his consent was valid. I'm not saying, however, that these are reasons to think that his consent for sure wasn't valid. This is a very difficult issue and one that you will have to argue for from your own perspective given the information that we have. But let's look at the final two parts of Passamani's three features of a proper study. So we just talked about informed consent. I think we have questions there, but it's not totally guaranteed either direction. So let's look at equipoise and usefulness. Well, in the case of equipoise, all the drugs that were used in the study were commonly prescribed antipsychotics. It seems like physicians didn't have any particular preference of one among the other as being better for patients, guaranteed. So it seems like equipoise was met. However, interestingly enough, clearly the treatment wasn't working for Markinson himself, so even if the other drugs by themselves wouldn't have helped him either, we might still have a worry that the doctor knew for a fact that this treatment, prescribing him one particular antipsychotic, was not an effective treatment for him, even if no single drug would have been an effective treatment. Maybe multiple drugs would have been an effective treatment for him, but his doctor would not do that. As far as usefulness goes, that's sort of questionable, as the article points out. It sort of depends on what we think are questions worth answering. So, for instance, the article discusses that perhaps the study was funded by a drug company in order to figure out whether or not its antipsychotic was had less of a weight gain side effect. Basically, people that took it gained less weight than people who took the other antipsychotics. So certainly that's a test of a side effect, and an important side effect for some people. And so we might think that that is a useful question worth answering. But other people might think that that's not a useful question worth answering, in which case the study is not necessarily useful. In either case, the study did not produce any usable results, but that's not the sort of question we want to ask when we ask about usefulness. Usefulness is something we determine prior to the study, not afterwards. Of course, some studies that initially appear useful turn out to be useless, but there's not a lot we can do about that. So finally, let's talk about the pillars of bioethics in research. So we already talked about the 3 general features, and I tried to fit them somewhat into the pillars of bioethics in the previous lecture, but let's look at the principles of bioethics in particular. Well, it's important to keep in mind that the principles of bioethics were designed explicitly with research in mind. However, that doesn't mean that it is clear-cut what is and is not ethical research. Unfortunately, even though the principles of bioethics were designed in the context of research, they do not give us easy, straightforward answers to what sorts of research are ethical and what sorts aren't. However, we can look at them in particular to figure out what sort of questions they want us to ask. Well, first, respect for persons. Respect for persons, or respect for autonomy, requires informed voluntary consent. But as we saw, it can be very tricky to determine when someone has actually given informed voluntary consent. Additionally, beneficence and non-maleficence require weighing the harms and benefits of the study. But there's questions about who counts and how much people count. So for instance, does the patient or the research subject count more than the future people who may benefit from whatever the research produces? Or do they count equally with those people? Do old people who are involved in the study count more than future people who don't even exist yet? These are questions that are hard to answer, especially hard to answer for a physician researcher. So remember, as a physician, the doctor should be counting the well-being of her patient higher and counting the harms to her patient as more problematic than other harms. But as a researcher, seemingly he or she should count all the harms and benefits equally. And then finally, justice. Justice demands equal treatment. Specifically, for our purposes, as we looked at the Tuskegee study before, and I mentioned prisoners earlier, specifically targeting vulnerable populations often will increase the chance of recruiting a subject. If you go after people who are poor and say, we're going to give you money if you participate, you're more likely to get them than you are if you go to someone who's not needing the money as much. But just because it's going to increase the number of research subjects you get, does that justify such targeting? So we saw in the case of the cancer research that they really need volunteers. They don't have enough in order to do cancer studies, and we think that cancer studies are probably pretty good. They're going to figure out ways to treat and cure cancer. But should they go out and target particular people, vulnerable populations, either under racial lines, gender or sexual lines, cultural lines, or socioeconomic lines? Should they target these people because they think or have a good idea that they're more likely to agree? Or is that what we would consider unjust and not justifying doing the research, even if the research is likely to benefit? So all 4 principles are at play in the case of research, and all 4 principles kind of push you in different directions and give you different things to think about. This isn't supposed to be an easy case. I don't know for a fact whether Dr. Olson did anything wrong in the case of Markinson or other patients. We have things going both directions. And so as you do your own work on your own cases, both within your bioethics committees this week and on your topic papers and throughout the rest of this session, keep in mind that there are different ways to go on these issues, and what matters most is how you argue for them, not necessarily what conclusion you draw.